story about nurse practitioner shortly.
Yeah.
And Jenny and I know each other. We work together, so.
Okay.
Yeah.
Okay.
Yeah,
Great.
kia ora, Jenny. Sorry, I didn't see you up there. I had a talk box and over your face. So I saw the baby.
That's all right. You missed the baby then, just saying good night.
Aw.
As soon as they see something going on, they're like, I'm coming over. You're like,
Beautiful. Beautiful.
Is everybody
Susie-
else listening to a rainstorm outside their window?
No, I'm in Wellington. I've got great weather.
Oh my
Yeah.
gosh. It's
And not in the
torrential.
Waikato either.
Oh.
Great.
I'm in Albany and it is literally torrential rain. I can hear it like, yeah.
Ah,
I'll be able to tell you how long it takes to get into the central city, Sarah Jane, because I'm in Grey Lynn.
Ah. See.
Nothing at the moment, but we can't look out the window and kind of see the rain coming from the north or the west generally.
no, I'm in Gleneden. It's here already, so it's not far away.
Okay.
ah.
Oh, you're in Gleneden, Jenny. Okay.
Apparently we're having a decent storm hit, so yes.
Kia ora, we have another new person that's joined, Karen.
Ora.
Karen.
Kia ora, everyone.
You're a Karen.
Kia ora, Karen.
So I'm probably a little bit random. I got sent the link from Heidi from iCams in Waikato. I've been doing some work with her in the mental health space, so she thought it might be quite good for me to pop along to this hui. So I'm a nurse practitioner working in school-based health services in the Waikato for Pinnacle Midlands Health Northwest. So.
Oh, very good. Okay.
We haven't met Karen because I'm nurse practitioner, mental health and addiction in the Waikato too. So finally we get to meet.
Oh, fantastic.
Crazy.
It's the way it goes, isn't it?
Yeah.
You get to meet people in your own neighbourhood. Yeah.
Yeah, exactly.
We're so busy. I can't even believe we're into July. It's crazy.
Yeah. Kia ora, Nola.
Kia ora. I just wanted to say hello. My phone's not very well charged, so I'll have to not be on video, but I work with Louise and I don't know actually how I got an invite, but I thought it sounds really cool. I'd like to just come in and have a look and listen.
Oh, good on you, Nola. Yeah.
Nurse and Addictions with Louise.
Yeah. Oh, good. The idea was to get the invitation out as widely as possible, and there was no restriction on who could register. So, yeah, it's great that you're able to come along.
Lovely, thank you.
Kia
So
ora,
I will
Suzette.
turn my phone off so it can charge.
Kia ora, Suzette. Shame we can't see you.
Just watching Whanera on Māori TV.
Watching what?
Whanera, Māori TV.
Oh,
It's
cool.
quite good. There's a whole stream of stories on there tonight. I met the kaiako, new kaiako over at Waioria that was on here. Chris, what's Chris's other name? Chris Selwyn.
Oh, I don't
Just
know that.
amazing people on here, artists. They just
Ah,
they're fantastic and Pakeke people telling stories about wairua. Yeah. All right,
Wonderful.
whānau, I won't keep you. I'll open us up and I'll hand it over to Tony. So nā mihi kia koutou. Nau mai hara mai kia tātou. Hara mai ki tēnei webinar I tēnei pō. Nā mihi ki te ao Māramatanga I tituki tēnei kaupapa. Ki o tātou kai kōrero. Oopsie daisy. Nā kai kōrero o tēnei pō, tēnā kōrua. Nō reira I runga I tērā mihi kia tātou, kia ino I tātou. E tō mātou atu nā I uhi mai tō koro ai aroha ki runga I a tātou. E haere pai roto I nā kōrero ka puta mai roto I tēnei huihuinga. E huihuinga nui I roto I nā mōhiotana o a tātou nehi. E whakaate atu nei ki a tātou mō rō rātou kaha, o rātou pūkena, I roto I mō rātou mahi. Mana ki hoki a tātou I tēnei pōtō mātou ata. I runga I tō ingoa tapu. Āmene.
Amen.
All yours,
You're
Tony.
Henry right. Thanks so much for that, and welcome everybody to this webinar of Te Māramatanga, the College of Mental Health Nurses, and a special thank you to our guests for tonight, Louise, Leonard, and Jenny, who has got another name. Jenny Smith. Oh, I was going to guess it said S. Yeah, and Jenny Smith. So we're very fortunate to have a very experienced nurse practitioner with us tonight, and also a nurse practitioner who's going through the training process currently. So we're getting, I guess, two different kind of foci of experience, which is great. So the process for tonight is that Louise is going to speak first, and then if you want to put questions through the chat, do that. Sarah Jane is going to monitor those. If they seem to connect directly to what the speaker is saying, they might answer those questions on the way through. If there are questions that maybe it would be good to hear from both speakers about, then we'll park those to the end. Or to the question time at the end, which will be from about 20 to 8 or maybe 7:45 onwards. So we'll get 15 minutes or so for questions. So do bring your questions. And welcome to everybody who's here. It's great to see a good number of people giving up an hour of their weekday night and getting involved in this professional activity of the college. So I won't say any more. I'll hand over to Louise. Tonight, Louise, and thanks for coming along tonight and agreeing to speak.
Ngā mihi Tony. Tēnā koutou katoa. I'll just start with my pepeha and then I'll lead off. Ko pūhanga tohoro te manga, ko nā toki wāta whā o rua te waka, ko Ngāti Pākau te hapu, ko nā pui nui tono te iwi, no ota ua, waima me tāhiki o ku tūpuna, kei kihiki aho I noho ana, ko Louise Tauhinu Leonard toku inua. I mahi ana aho te whata ora Waikato me University of Waikato, tēnā koutou, tēnā koutou, tēnā koutou katoa. And I want to start by saying thank you for the opportunity. Thank you for the invite from the college to come and speak tonight about my journey, I guess, as a nurse practitioner and what's inspired me and what keeps me inspired, I guess, going forward. So hopefully you saw my little bio, bit of a blurb about who I am. I was thinking about what inspired me to be a nurse practitioner in mental health and addiction. And I guess when I started this journey, I'd probably been about 10 years working in drug and alcohol services and came into that work in Australia. So in New Zealand, I mean, I trained as a registered general and obstetrics nurse back in the day, hospital trained in the mid 70s, early to mid 70s, and then ended up leaving New Zealand for about a 20-year period from about the 80s. In Australia, I wasn't sure that I was going to remain a nurse, and I did a number of things, but one of them was I undertook a Bachelor of Art Psychology because I thought I was going to jump ship and become a psychologist. However, I continued to work as a nurse and was a clinical nurse consultant in Australia in the area of drug and alcohol. and loved that work, and then decided to return home. And I also upgraded my nursing qualification whilst there to a Bachelor of Health Science and Nursing. Then returned home in about 2004. Time to come home, time to reconnect. Yeah, lots of reasons to come home, and it was a good move. And then came back to CADS Hamilton. And at the time, there were no nursing roles within CADS at Hamilton. In Hamilton, there was one about to begin the next day, but so I came on board as in a counselling role, and then started to work with Suzette and develop a clinical nurse specialist role, and start to head down that pathway. So I probably started postgrad study pretty quickly once I got back to New Zealand. Did a postgrad certificate in addiction and coexisting disorders through Otago University, and loved it. Also, I loved coming back from Australia, I loved the kind of size of the workforce in the sector here in New Zealand, because you weren't lost in the crowds. I had a lot of support, which was great. And then at the time, because we're talking about, pre-2010, because that's when I finished my master's, then moved to University of Auckland to start to head down the nurse practitioner pathway, because it wasn't developed at that point at Otago. And then did my postgrad dip and into my master's, and was lucky enough to have Tony O'Brien as my academic mentor through that journey. So I was endorsed in 2012 and into a role by 2013 at CADS Hamilton, and have been there ever since. And I think in terms of what inspired me is coming from that background of psychology, etc., and loving aspects of drug and alcohol nursing, because it also kind of combined a lot of biological, I guess, biological as well as psychosocial, etc., etc. I guess I was really used to doing comprehensive assessment, but I wanted the autonomy. I wanted that next level of actually being able to make decisions and get going with, and decisions around diagnoses, and get going with a treatment plan, not having to wait. So it was all about that for me, removing some of the barriers to timely treatment, particularly for the population that I work with, who are stigmatised and disenfranchised and don't trust services because they've often had bad experiences. And so, nurse practitioner seemed like a really good fit to be able to use what I had to really engage with the population and do as much as I could, kind of in a timely fashion. So that's really what inspired me. In terms of my current role, so these days, I was full-time at CADS for many years, and then probably about 4 years ago, I started doing some academic mentoring with University of Auckland first, and then later with University of Waikato. But these days, my role is 2 days a week at CADS in Hamilton and 3 days a week with the University of Waikato, co-convening the nurse practitioner program. And so I guess as in terms of my clinical role, so as a nurse practitioner with CADS, so within the Mental Health and Addiction Service, so CADS being Community Alcohol and Drug Service, my role, how that looks is I'm part in a way, I'm seen as part of the medical team, and that is not been a problem for me. We have good collegial relationships, and it hasn't limited me. In fact, if anything, it's supported me and enabled me to really grow and develop. It's not been without its challenges along the way, and I'll flag that professional supervision has been really important to be able to stay the course at times. But yeah, so I'm seen as part of the medical team, and so but not only as part of the medical team, it is that bridging across to nursing. So so what that means at CADS for me is that I'm a prescriber within the OST opioid substitution treatment program. So I have an allocated cases that are my cases. I'm responsible for. I review them regularly, but as in terms of their medical reviews or prescriber reviews, and I'd add that for most people on the opioid substitution treatment, there's a lot of comorbidity. There's a lot of mental health comorbidity and a lot of physical health comorbidity, and a lot of it's untreated. One of the good things, I guess one of the things that an opioid substitution treatment program enables us to have is long-term engagement. But at the same time, that relationship, that therapeutic relationship is really important. And I know there's often a difference in the way that I engage with patients compared to some of my medical colleagues. I don't want to sound negative. I just know there's a difference. And sometimes I seem more able to get good engagement. And maybe that's because I've got those things like health literacy and equity and health promotion and all of that disease prevention in my head, as well as the medical stuff that we're doing. So in terms of the opioid substitution treatment, then that'll be face-to-face reviews with patients, as well as telehealth if people are out of area or whatever. I also see people with alcohol and other drugs as their main substance problem. And again, there's the complexity of comorbidity, and physical or mental health or both combined. So complex cases requiring kind of a lot of not just assessment, but also, I guess, really careful planning and coordination of that plan. SACAT is part of my role. So SACAT being substance addiction and substance, I've forgotten it, assessment, and anyway, SACAT's gone out of
compulsory assessment and treatment.
Yeah, that's it. So my role within SACAT is as either an approved specialist or as the responsible clinician. So the roles swap back and forward. I don't do the authorised officer role. That's for others in the team. So I guess the psychiatrists and myself, etc., do either of those two roles. So I guess the other main part of my role is that I oversee really the admissions to the alcohol and drug assessment stabilisation beds, which are our detox beds. We only have 2 beds in the Waikato. Well, we have 2 beds that we permanently have access to, and they are situated on a medical ward. There is another bed out at Thames, but we don't run that bed. The physicians do out there, and it's not always available. So I guess that needs quite a bit of coordination and a lot of assessment, because we have to bring those admissions in a timely fashion because we've only got 2 beds. So we're kind of moving people through. So I work for CADS on a Tuesday and a Wednesday, and those are the days that we're bringing in admissions and discharging patients as well. And it works pretty well. I mean, it's not ideal, but we've had to take what we can get. We'd rather have 2 beds there than not be able to do that part of the pathway. When I say it's not ideal, what I mean is it's a busy medical ward, and so providing, our tangata whaiora with enough support is not easy up there, in terms of the psychosocial support, etc. So they're all planned admissions though, because all the full assessment and the treatment planning needs to happen before they're admitted, because they're usually admitted for a 7-day stay. Otherwise we'd end up with blocked beds and we'd be in trouble. What else for me? Mostly those admissions are for alcohol use, severe alcohol use disorder, requiring inpatient admission for a safe detox. But increasingly, we're seeing some nasty drugs like GBL and GBH and other things emerging, which are really worrying. And they're often anesthetic type drugs with a short half-life, and people get into trouble in terms of the severity of their dependence really quickly and have some pretty awful withdrawals, often accompanied by a delirium. So also part of my role would be for both, whatever the substance is that the patient, that the tangata whaiora is presenting with, would be around assessing mood disorders, assessing and treating mood disorders. Also diagnostic clarification around other DSM-5 diagnoses. God, you can see when I changed DSM-4. So diagnostic clarification, and including around ADHD. So, I mean, it's great that things, access to assessment and treatment for ADHD is opening up. But, it's not very long ago that it was just about impossible for people to access, and including at Waikato, because there are not many, the psychiatrists weren't willing to do it. But in a way, I think it's nurse practitioners coming along nationally that have really challenged that and said, well, they meet criteria, so we can't not treat. And so there's been a groundswell nationally, and a lot of that work has been done by Anna Elders, who's really advocated for that change, and others. And I guess in terms of treatment of psychosis, I guess that would be, so for me, it's usually in the context of a drug-induced psychosis. So might be and a delirium happening alongside, some of these weird and wonderful drugs that are out there. Although, I guess the other time I would be involved in treating psychosis is when I've got an opioid substitution treatment patient who destabilizes and becomes psychotic, and then it would be up to me to start treatment while we're getting, other people involved in terms of the other teams involved. I think that's me in my role, my clinical role, and I'm happy to answer any questions that you have. No question is a silly question. So, if you've got questions, please ask them now or at the end.
So I guess now would be the time if anybody had a question about AOD specifically. Louise is well placed to answer that question. So if there's no takers, Louise, I'm never stuck for a question. But in managing those 2 inpatient beds, do you create the treatment pathway for those individuals and then hand that over to the ward when you finish for the day? The on-call medical doctors manage anything that emerges after hours, or do you provide advice after hours as well?
Yeah, good question. So they are admitted under us, under CADS. A treatment plan has been begun in the community and been endorsed by the MDT in the community around, the longitudinal pathway for the tangata whaiora in a way. When they come in for admission, I'm doing the assessment at that point. So it's assessment and treatment planning and diagnostics around that admission. Because there's, as I said, there's a lot of untreated or undertreated comorbidity, which needs addressing as part of safely detoxing and stabilising the patient. In terms of after hours, no, we don't do our after hours, but we link with the psych registrars on call. Usually we don't need to involve people after hours, but there is that backup. And most of the psych registrars have rotated, or not most, but there's a lot of them have rotated through CADS, and so they know the way that we work and they're familiar. So that actually works quite well. Mm-hmm. Yeah, but it does take kind of some good planning to make it work, because you can come unstuck very quickly if the tangata whaiora and whānau don't have a good understanding of what's going to happen. And yeah. Mm. 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 Does anybody else have a question for Louise, or if not, we can just introduce Jenny and let her.
I do, Tony. I actually just wanted to ask about the nurse practitioner role in particular, Louise, not necessarily about the CADS part of it, but what would you say has been your biggest learning curve going from, because you've obviously had a wealth of experience as a nurse in both Australia and in New Zealand, but what's been your biggest learning curve transitioning into being a nurse practitioner and the role?
Yeah, that's a good question. Yeah, it was still a steep learning curve, and I think it's that for a number of reasons. It's having to step into that autonomous role and being ready to do that and be the decision maker and take that responsibility. So it is around the diagnostic and clinical reasoning, getting up to speed with that. I mean, I guess a strength for me was I'd had broad general nursing experience in a range of settings. So I had seen lots of unwell people. So I think if you don't have that, it's a bit of a disadvantage, because you still, yes, of course you need all of the mental health nursing skills. However, you need that understanding of, deteriorating physical health as well. But yeah, I think the biggest challenge is really stepping into that diagnostic and clinical reasoning and backing yourself with it. It's a process. You're expected to do it from the get-go, but you're expected to do it as a novice at a novice level. But yeah, that takes time to really gain your confidence in, I would say.
Thank you. Can I ask one more question just as as an add-on to that then? I suspect that quite a few people have joined the webinar tonight because they're interested in pursuing a nurse practitioner pathway. So I'm curious to know if you would have even just one piece of advice for those people in terms of pursuing that that might help them along the way.
Yeah, lots of advice. And I can say a little bit now. We can say more at the end if you like. But I think it's about getting yourself ready across a range of domains. So well set up in terms of whatever organisation you're working in. So good organisational support, developing your clinical skills as much as you can, you know, when you're on your postgrad journey, actually applying what you're doing. And it's not always easy, because sometimes it's not the way things happen in the service that you work in. So you've got to really advocate for yourself to be able to apply those skills as you're developing them. Yeah, so getting clinically ready and making sure you're communicating with the right people too, so that you have support.
That's really helpful. Thank you very much, Louise.
Well, perhaps we'll switch now and introduce Jenny. Jenny, thanks for agreeing to come along. You've got a slightly different perspective on nurse practitioner from your clinical practice setting, and also your, as I understand, on the pathway towards nurse practitioner. So great to have you here, and I'm sure that people are wanting to know what's it like for you on that journey right now. So over to you, Jenny. Thanks for coming.
No worries, thank you. It was really interesting for me to hear Louise as well, who's obviously been through it. So that was really good. So I just hopefully wanted to just introduce myself and the role a bit more. So I currently work at Liaison Psychiatry in the Waitemata region of Te Whatu Ora. I work at Waitakere Hospital. So within Waitakere Liaison Psychiatry, we have the ED function as well as the medical wards functions. So from my perspective, it's two very different skill sets. So as you can imagine, coming into the ED, there's a lot of sort of the acute presentations, and you're dealing with the higher end of the mental health spectrum in terms of mental health needs, admissions, respites, overdoses, that sort of thing. And then as you move through to the medical wards, you're moving through to the complex medical situations. So the functional disorders, the dementias, and at Waitakere we have pediatrics, adults, and older adults. So in ED I only see adults, whereas moving through to Liaison Psychiatry I see the complex medical across the board. So it's two very different jobs and two very different roles, and it's each one has its positives and negatives. So that's kind of what I'm doing currently. I come from a background of before Liaison Psychiatry, I was the charge nurse of inpatient unit. Before that, I was in epi. And then before that, I was in home-based treatment. So I'd been quite well-rounded in terms of age group, inpatient, outpatient. So I felt like that was quite beneficial walking into a liaison role, which is very wide and very medical model. So it was very good from my perspective to have that set of skills from different community groups. So that was really good. So that's a little bit about me and where I came from and what my current role is now. I just wanted to do a few quick mentions, if that's okay, because being in the nurse practitioner program, I feel is a real privilege, and I think it's a good opportunity to thank the people that got me to this point, because obviously a success for me is not just a success for me, it's a success for everyone. So I just wanted to acknowledge the work of Auckland Uni, because at the start of this year, there was a lot of uncertainty around the nurse practitioner funding and all that sort of thing, and the other nurse practitioners that fought for us to be in this position at this current time. So I just wanted to acknowledge a lot of work that went in for there. I particularly want to mention our mental health mentors, Carrie and Sarah, who have been really supportive through us this year. I just wanted to also quickly mention the senior nursing team at WDHB for supporting. I wanted to talk briefly about our mentors in the field. So it's, for me, that's Dr. April Clugston and Carmel Rigby, who's an ED. And then also I can see Mary Rose here, who's also one of my fellow NetP interns. So that's really great to see a few of us here, and also like the floor staff, because when you're holding a dual role of NetP intern and then your own role, when you step out to take that time for yourself, for your learning, it puts a lot of pressure on your colleagues. And I don't know that that gets acknowledged a little bit. So I just wanted to say a bit of a thank you, because I know a few of them are here. And to kind of reflect Louise's presentation was why I wanted to be a nurse practitioner in the first place. And I think it's best summed up by an example, if I can give one, if that's okay. So an example of a case that I had in ED, obviously I was working in liaison psychiatry before I came into the nurse practitioner program. And I got referred a young woman in ED, and she was referred to me for suicidal ideation. The police had brought her in because she had a fight with her partner, and the woman, we'll call her Ray for this example, she had expressed that she wanted to end her life, and she'd walked off, and police had brought her in a 109 into ED. She had been cleared by the medicine. She'd been also, they wanted her to see the social worker because it was a fight between her partner and her. It was a domestic violence sort of incident. And the social worker was quite confronting. She said to me, well, domestic violence agencies can't manage that sort of risk, so there's nothing I can do. And that was quite confronting, that both services sort of were not in a position to help someone who was clearly in need of some assistance in multiple areas of health. So in terms of Ray, she had experienced domestic violence in all aspects: physical, sexual, emotional, financial, and she'd been isolated from her family. She had lots of mental health history with emotional dysregulation and CADS in the past. She had a history of sexual abuse. She also had a lengthy medical history with pelvic inflammatory disease, fallopian tube ruptures, and surgery for that. And she also was not taking a lot of medication, which was prescribed. So she was there for mental health, for help with her social, and she was also bleeding heavily on her periods, and it was 6 to 12 pads and soaking through at nighttime. So it was quite a significant bleed above normal. And the other services, you know, the ED team, which I understand, said it's not life-threatening, which I can understand, but also the GP can follow this up. But also we know that her partner's got her cards. We know that her partner's got her car. We know that she's got no support. You know, so how can GP follow up? How can she get follow up? And then the social worker kind of saying that domestic violence agencies can't manage this at the moment with what's going on. And it was sort of at that point where I really thought, if I was a nurse practitioner with a bit more power and a bit more mana, I guess is a better word, behind me, then I could address the situation better. And it was sort of at that point where I thought, I'm in a really privileged position in liaison psychiatry. I need to have a good medical knowledge. I need to have a good mental health knowledge. And I have, obviously, ED kind of sees the social side of things as well. And I've got that knowledge behind me, and I could make a difference. I could address these inequities. I could address these stigmas, and I could make a difference for people in my setting. So it was sort of seeing things. That was just one example of things I saw over and over and over again, of where I thought I could really make myself a nurse practitioner role, and I could be a nurse practitioner for the West Auckland community, which is a, you know, just high Pacifica Māori population, lower socioeconomic area. That's where I kind of thought I could make a difference. And so that was kind of what drives me to be doing what I'm doing. And I kind of need a reminder of that frequently, because the nurse practitioner intern year is quite stressful. not going to beat around the bush. I'm definitely not here to whinge, but it's not an easy journey, as the fellow nurse practitioners and nurse practitioners here can attest to. So the expectation on you as a nurse practitioner is definitely a lot of learning, which is both a positive and negative. I love to learn. I love to learn new things, but you put, I think it's something like 8 hours of additional learning, plus your assignments, plus being and showing leadership activities, plus teaching activities, plus I was holding a senior role as a clinical coordinator, and then mum to 2 kids and wife, daughter, friend. It's quite an overwhelming year and amount of workload that you need to have, and I think it's challenging. So reflecting back on what drives you is really helpful, and it was really helpful to have these talks with people about why you want to do what you want to do, because it makes the fire in your belly, right? It what makes you want to try. So I think that was somewhat of a challenge for this year. I think we also got off to a challenging start for our year because of the uncertainty about the nurse practitioner program and those things going through. And I think it was a bit of a shaky start when you were already feeling perhaps not as confident about going in as you want to. So I think the university and, you know, the seniors and the DHBs, I know they did a lot of work in fighting for us, and I'm grateful for that, but it made it shaky for us as well to start. And I guess the current staffing, funding stuff going on within is tricky as well, because you're stuck in that conundrum from helping your colleagues and you see them struggling, but it's your time for your learning as well. So you're having to balance that, and that's hard as well. And most people are really happy for you and they want to help you. But there is always the occasional rubbings into the different roles and how that's going to look, which is challenging. So I think that's been a learning for me, is learning to say no and take time for myself and for my learning needs, which has been hard, but it's like everything, it's a part of a life lesson. So that's been good. I think in terms of the positives for me has been, as well as doing all the academic stuff, we have to have formal supervision from someone, either a nurse practitioner or a psychiatrist. So I've had 2 really wonderful people helping me. So April Clugston's a psychiatrist, and she is an older adult psychiatrist as well as a liaison psychiatrist. And Carmel Rigby is a nurse practitioner in ED in physical health. So she was my nurse practitioner for my secondary placement, but as well as she's been there because I also work in the West ED. So she's been very helpful in terms of helping me with that. And that's been a really positive, because it's a different sort of relationship where, you know, you'd go off and do your assessment and they'd come back and talk to you, and you talk through diagnosis, you talk through medication plans, you talk through what you should and shouldn't do and what you're thinking, and challenge your bias and have those kind of really robust discussions. And it's both really good when you get to the same place, and also really good in a different way when they challenge you and you learn something different, because you're stepping up, you're becoming the leader in the care, I guess. So I've been really privileged to actually get that time to sit down with the people and get them to put time into me, which has been really good. And then obviously I think I have been enjoying the learning overall from the nurse practitioner program, although I've come to the decision of, I don't know if you guys know much about the knowledge paradox, where the more you learn, the less you actually know. So I think as a clinical coordinator, being in lots of roles, of senior roles, and then I was quite, like I knew I hit my ceiling, I was there, and then sort of that ceiling's been, and it's gone. And I'm less sure perhaps than when I started. And that's quite a scary place to be. but it's also quite an awesome place to be as well. So it's just keeping on going with that a little bit. And I think the other part of learning that is really I've been struggling with this year is, and it's been quite a few of us talking about it, is the feeling of imposter syndrome. And so it's just, feeling, can we do it? Are we good enough? Should we be here? And then, sitting in with our medical colleagues and then with our physical health colleagues, and what actually is it going to take for us to feel secure in ourselves, and will we ever feel secure in ourselves? And that's perhaps something Louise could answer, because I'm still learning that one. So that's sort of been my year so far, but still going on, only started semester 2, so that's sort of where I'm at. So yeah, any questions, feel free, fire away.
Yeah, so do feel free, everyone, to ask questions. We're hearing a lot of different experiences about starting out in the pathway and having been there for some time. So yeah.
Could I just jump in briefly? I just wanted to acknowledge, because I was talking about the support that I had along my journey, and I wanted to acknowledge Daryl Deering, who's online tonight with us, because Daryl was certainly very instrumental in getting me to nurse practitioner, and I was fortunate enough to be the first nurse practitioner in the addiction field in the country. It was largely due to Daryl's hard work beforehand and then supporting me along the way. Look, I just wanted to talk all what Jenny is saying. I think you've said it really well. I think you've described the journey really well. It is a tough journey. There's no doubt about it. It's a tough journey, and you have to be ready for it. And it certainly sounds like you are, and you're doing okay. And as I just wanted to mention that, the importance of being kind of ready for the journey in a pastoral kind of sense in your personal life, because you have to have, I guess, enough space for this. And it's hard to create these days, enough space in your life, in your personal life, and enough support to be able to head down this pathway as well. And so, the timing of when you do it is important. It is a really pressured year, and with the new funding, when we've got an outcome to it, it's kind of been acknowledged that this is a very pressured year, and there's been consideration for the 6 months pre-entry to the program and the 6 months post-entry to the program. We're not 100% sure what that'll look like, but yeah, for people going through with this 1 year full-on practicum, it is hard work. And just wanted to also acknowledge, Jenny, that the uncomfortableness of having to stretch like this, and extending that skill set and moving from one scope to another. It's an uncomfortable place to be, and I think we've all been there in terms of feeling like an imposter at some point, and it doesn't go away just because you're endorsed as a nurse practitioner. Then you've got a whole new set of imposter stuff to deal with. But as long as you've got enough support and enough people that are backing you, you can overcome that. Yeah. And the other thing I just wanted to flag is the importance of developing relationships with the person that you want to be a clinical supervisor. So really important that you don't just take it for granted that you're going to be able to pick someone and they're willing to do it, because it's a lot of work, it's a big commitment, and they need to have a relationship with you. know who you are and where you're coming from. That's all I wanted to say.
I make just a question, Jenny. Kia ora whānau, apologies for being late, I had to travel. Jenny, you described almost, and Louise, walking into a space and the uncertainty of walking into a new space. And I'm really interested in how you kind of hold on to the nursing role and how your nursing influences your practice as a nurse practitioner. And if I think of boundary spanners, you know, you being into medical roles who are very influential in our system. So I'm just kind of interested in your thinking about now, reflecting on your nursing role and how that informs your nurse practitioner role.
I think for me, it was something, and a concept that was sort of introduced me in my undergrad, was that nursing is both a science and an art. It's not just a scientific medical thing. It's about how you approach things and the wider, the softer side of how things influence. And I think the nurse practitioner role encapsulates that well, because you have the medical knowledge of the doctors, and that's really great. But you also come from that more humanistic model, and that's the role I really see for nurse practitioners, or that's for myself, I guess. I'm not a nurse practitioner yet, but that's the role I hope to see for myself, is that ability to connect and that ability to deliver care that is meaningful and that will make a difference and address those inadequate, those discrepancy in healthcare. I guess, Louise, do you have any thoughts on that?
Yeah, absolutely. Yeah, I think for me, you know, I've always loved the art of nursing in terms of, you know, that gaining therapeutic rapport, the walking alongside, the understanding another person's worldview. You know, all of that stuff is just that's what has kept me nursing, and yes, it's been great to have the extended skill set and that kind of medical knowledge and that other way of thinking. However, without that ability to engage, and without that ability, like really engage, get people on side, then it doesn't matter how fancy your tricks are, you're never going to see people again. So I think that's the thing that I really love to bring to the table, and that it's foremost in our thinking around equity and health literacy and all of those kind of things, the social determinants of health, that it's all part of what we bring to that space that we step into. And I think our focus is much broader, actually, when I compare it to my medical colleagues. You know, I absolutely acknowledge the depth of their diagnostic skills, and I need access to that. You know, having access to that is great to be able to bounce around ideas. But yeah, there's something that as nurse practitioners we're able to do in terms of engagement and communication that I think gives us a real advantage.
And Roa, you've had your hand up.
I did indeed, Tony. Thank you for the kōrero whānau. Mihi kia koe, Daryl. No mai hara mai kia tātou. Good to see you. Been a while. Thanks, Jenny. Thanks, Jenny, for sharing your journey and your beginnings and how it's been for you in this first year, I suppose, on the journey of nurse practitioner. And, you know, I suppose it's about that leadership that we're talking about in your conversation and sharing of your journey. And I remember someone saying to me, you know, tell everybody what you're doing, everyone that's part of your life, part of your workspace, part of your whānau, tell them what you're doing so they can support you. And I found that I was never I was always shy to share what I was doing. And I found that telling people what I'm doing was the right thing to do. And so people ask how you're doing, people ask where you're up to, people ask, how's it been? And then they say, and your job, and you're doing that as well. So I think the more people you tell, the more the journey becomes a little lighter. The nursing skills that we're talking about in the journey of the nurse practitioner, I kind of hope that the art and science of nursing is part of all our journeys, and so is leadership. But I think there's a skill set that I've heard from Louise tonight, and your journey as well is teetering on some of that journey, but it just gives you a beautiful insight of Louise's journey of what it is to be a practitioner around that autonomy and making those great decisions because of that skill set that you have as a nurse practitioner, and not afraid to call it for what it is, whether it be a diagnostic or whether it be a scientific, and whether it be just a basic nursing action. These are all part of you and I and our practice as nurses. But to hear Louise articulated and hearing your beginnings of your journey, we've yet to hear the rest of it. So I can't wait to hear the rest of your journey, Jenny, that's going to sound just like Louise's. So, I mean, I think it's quite encouraging to hear the lumps and bumps along the way. And it's kind of nice that, yep, we're all human. Yep, we all go through the same things. It's so cool to hear, Jenny. So thank you. Thank you so much for sharing that. Those little snippets of what it's like to go back to study, have a whānau, hold a full-time job, all those things that come with it. So thank you so much for sharing. Kia ora rau atu.
I don't have a question, but I just have a comment I want to make. Well, I do have a question at the end of my comment. I just wanted to acknowledge, Jenny, the level of vulnerability that you have shown, I suppose, in saying the challenges that you've faced in this year or the start of your nurse practitioner training program. And Jenny and I work together. And so I just wanted to acknowledge and say to you, as an outside observer and somebody in nursing leadership, you might feel like that imposter syndrome might be taking over, and you might be feeling that, you know, you have no idea what you're doing, but outwardly you're presenting as the swan on the lake. You know, it's been lovely to see you transition from your previous role into the nurse practitioner internship. So you're doing well, you really are. And my question then, I suppose, as well, kind of goes to something to what you had said, Louise, in terms of the three things that you identified about what would support somebody on the nurse practitioner journey, and one of them was around organizational support. And as somebody in a nursing leadership position, I suppose, taking that question and putting it to Jenny, is if we had a magic wand, is there anything that we could do or that you would suggest that would be helpful to, from an organizational point, to help support you more? Because I know it's challenging when you're juggling so many different things.
Obviously Sarah Jane, it works in the same DHB as me, so my team in particular we've had a lot of resignations, and the staffing it's no one's fault. I want to be really clear about that. It's no one's It's not the DHB's fault. It's just what it is. People have moved on. They've been there for a while. They've gone to different DHBs. They've reached their capacity in the liaison psychiatry role. But I think for me that covering the ground floor to allow for the learning to happen has been what I think from an organizational level would be the main thing that I can identify from my point of view. But then that also reflects on me as well, because it's been my journey of learning to not, oh, I can just quickly do that, or I can quickly do that on my nurse practitioner day. You know, my journey of saying with kindness and empathy, I understand that ED is not covered, but this is my nurse practitioner day, and I really need to be reviewing with April or being with Carmel to talk through all these things and learn, you know, why it's, you know, this and why it's not that, and what your thinking is behind it. And that's, yeah, I think that would, if that answers the question. It's not a, yeah, I don't mean to sound blamey, because it's not a blame thing. It's just a.
What I heard was, sorry, go on.
Yeah.
I was just gonna,
yeah.
You go.
Just how it is, I guess. Yeah.
Well, what I was going to say is what I heard there was really around supporting you to maintain your boundaries. That's kind of what I heard there. Thank you.
Okay, Louise has got a question, and we might make that the last one, because we're 3 minutes to 8, and I want to invite Henry Roll to close for us. Louise.
Question, quick comment around the saying no, the setting boundaries. I think that's part of the transition as well, in terms of your identity shifting. And what I mean by that is, as senior nurses, as very experienced nurses, you get used to multitasking, to doing things on the run, to doing a whole lot of stuff at once. And then suddenly you've got to protect your time, and particularly your thinking time. And so that's where the saying no, the closing the door, can you tell me about this later when we can sit down and I can hear it fully, becomes really important. So yeah, I think it's part of that shift. Yeah, and it's like another uncomfortable place.
Yeah, no, very good, very good way to finish off. I think thinking about making that transition into kind of working differently, and how that's as much of a learning curve as learning all the assessment and pathophysiology, etc. Okay, so we'll wind up the talk for now, and thanks again to everybody for attending, and especially to our two speakers, Louise and Jenny. It's so good to be able to hear nurse practitioners speak and tell others about what their experience has been. We weren't able to do this, Louise, when you were doing your nurse practitioner training. There were no experienced nurse practitioners in mental health to listen to, and there were very few new nurse practitioners coming in. And also just to acknowledge all of those in services, managing services like Daryl and others, Suzette, who have supported our nurse practitioners to step forward for that role, and knowing that they're committing a lot of time and energy, and they could have a more comfortable life without doing that. But without the support of the nursing leaders, it wouldn't be happening. All right, well, we will stop now, and Henry Rowe, I'll invite you to close.
Kia ora, Tony. Thanks, everyone. What a beautiful night it's been. Lovely having you in my presence, in my house. So ngā mihi kia koutou. Kia inoi tātou. I hau mai rā tātou I raro I te maru o tēnei kaupapa o te ao Māramatanga. Nā I whiu te rākau kia mātou, kia whakarongo, kia kōrero rohia te kaupapa o nā nurse practitioners. Mene atu kia rāua I tēnei poto mātou atua. Manaki hoki a tātou, e hoki pai, I wā tātou whānau. Inu nei tēnei pō, manaki hoki a tātou, me wā tātou whānau. Inu nei tō inoa tapu. Āmene.
Āmene. Kia kite, everyone. See you at the next webinar.